all over world, and she's here to give the talk. And I welcome on behalf of IAPTNSA, I welcome Dr. Arun Gar, and he's from Bangalore. He's going to talk about a foreign body ingestion in children. That's also is a very relevant one for us. And previously we thought of gastroenterology means it will be a tertiary care center, but now it's in the primary health center or even that's a rural area also. It is one of the important gastroenterology topic. You are going for chronic diarrhea and liver disease. So many things are there. So definitely we need to enrich our knowledge, basic things about the gastroenterology and hepatology related things. And once again, I thank each and every one of you to be here. And I think you will enjoy today's program and definitely will be enrich our knowledge. Thank you very much.
Thank you so much, Dr. Rajendran sir. I'm sure everybody will enjoy the interesting session and waiting to hear from Dr. Neelamon and Arun Garg. It will be a feast to the ears. While we say that, we are very happy to introduce our academic coordinator, Dr. Singarvelu sir, academic advisor, Dr. Singarvelu sir, who has been traveling wide for his presidential elections. In spite of that, he makes it a point to attend all our meetings as well as coordinate experts who are joining this program. Dr. Singarvelu sir, over to you for your felicitations.
Thank you, Narmada. Good evening to all. Greetings from Surat, our past president Dijan's hospitality place from where I am attending today's program. The most respected dynamic president, Professor Dr. Rajendran, who is making every scientific program very useful to all our pediatrician and postgraduate, and we ably supported by Secretary Narmada and Rajkumar and our past president-elect, and our academic coordinator, Dr. Thiru. Today's program is always attended by our none other than our teachers of teachers, Dr. Srinivasan sir, and PRC sir also has joined from abroad, and our past president Dijan Sastry also sir is attending with me, and so many stalwarts are attending today. I am happy that within a short notice, our president-elect Professor Neelam immediately accepted our invitation to be with us since she is traveling from, she was yesterday with us. Today she is traveling from Delhi. She just got down from the airport. She will be joining soon. Another leading gastroenterologist from Bangalore, Arun Gaur, my good friend, where I met him several times in conferences. Moment I called, immediately he agreed, accepted my invitation. So both the speakers will deliver a very good. I don't want to be in between the scientific program talking too much. But once again, thank all the of my president, Dr. Rajendran, and all others for giving the encouragement and support so that I am traveling everywhere. We are getting good response all over, and a lot of national dignitaries like Harpreet Singh, others also joined. I welcome on behalf of all of you. Thank you. Over to Narmada.
वाईफाई से कनेक्ट नहीं कर रहे क्या? डोंगल से क्यों कनेक्ट कर रहे हो?
इसी में वो काफी बड़ी टॉक है, वीडियोस हैं इसमें.
Narmada?
Yes, sir. Can we?
If he is not, I think sir is not ready as a formal with the president permission of a formal 2 words by our past president Dijan Sastry sir.
Yes, sir.
Sir, Dijan sir.
We are very extremely very happy to
Yeah,
have
yeah.
Dr.
Can I
Digant
go?
Sastry amidst us. Sir was my president when I was executive board member, and he used to encourage us a lot. And Dr. Singarvelu sir was also at that time. So he's extending his hospitality, and he has got a very, we have all enjoyed his hospitality when he was a president. Sir, over to you for your kind words, sir.
Yeah, no. It's a pleasure to have the friend coming to your home. And
Yes.
it reminded me my election days where I traveled. I think I traveled many parts of Tamil Nadu, Chennai, Madurai, then Tirunelveli, then Erode, Salem. I think almost you can you name the city, Coimbatore, all the places, Trichy and Tanjavur, all the places, and the love and respect which was extended to me, I still remember. And so I feel that in IAP we all are friends, we all are working for the children, working for the well-being of the children and for the organization. So naturally, when a friend is coming, we enjoy his company. And today we had a very good academic annual conference, and we got his academic inputs also in the conference. I know about the TNS activities, most vibrant state chapter. And I still remember 2006 NCPID, it was in Chennai. And we were surprised to see the hall was full of more than 600 delegates, even at 6 p.m. So, so that speaks about our members from Tamil Nadu's interest in academics. And I have quoted this at many places, and I highly appreciate it. So this activity again, the inviting the stalwarts and getting benefit of their knowledge and passing it to the members is a good activity. Carry on this great work. My best wishes to all of you. And thank you once again for all love, respect extended to me over these years, as well as giving me opportunity today. Thank you.
Thank you, sir. Thank you so much for joining with us. Yes, definitely you travel wide and everybody recognizes you immediately. We're very happy to have you in all our programs. Sir. Thank you, sir.
And always when your team member are there, it is like meeting a family member.
Yeah, that I always say, sir. So IAP is it bridges across the borders, and it brings us friends close together, and we have friends all over India now. That's the best part of IAP. Yeah.
Absolutely.
Thank you so much, sir. I think our speaker is ready. Sir, over to the academic coordinator, Dr. Tirumurugan, sir. Dr. Ashwath, the main coordinator of the program, is little ill, and he'll be Dr. Tirumurugan will be coordinating the program today. Over to Dr. Tirumurugan, sir.
Thank you, Dr. Narmada. And I think without wasting much time, let us move on to the topic, and then we can have a lot of discussion at the end. So over to Dr. Arun Garg for his first session.
Yeah, can you introduce the speaker as Dr. Ashwath is?
Yeah. Dr. Arun Garg is American Board Certified Pediatric Gastroenterology working in Bangalore. And he's one of the eminent gastroenterologists in the country, and we are really thankful to having him here with us to talk about a topic which very often we encounter in the pediatric practice and with a lot of queries. So I'm sure we'll have a lot of doubts and it will be cleared by Dr. Arun. Over to Dr. Arun.
Good evening, everyone. Thank you for having us here, and it's always a pleasure to share our thoughts and the wisdom with our colleagues. So today I have picked up a very common topic that we pediatric gastroenterologists and pediatricians see in our day-to-day practice. So we will be having just some introduction and followed by some cases, and we'll have some interactive section to understand how we need to manage these cases and what our basic understanding is and how we can take it further. As we know that the children, they tend to explore things by putting in the mouth. So the most cases of foreign body ingestion occurs in children less than 3 years of age. We know that commonly things that children put in the mouth are, are the coins, button batteries, toys, the part of the toys, magnets, safety pin, screws, marbles, bones, and sometimes the food boluses get stuck. So when we talk about the anatomical part in our esophagus, there are 3 places where the foreign bodies tend to stuck, most commonly in the upper part in the thoracic inlet, then at the aortic arch and the right mainstream bronchus junction, and then at the GEJ junction. So what are the risk factors? Younger the child, more the risk they're gonna explore and put things in the mouth and things will get stuck. Any congenital malformation, any surgeries, any anatomical things, any gastroesophageal reflux, and with the allergic things, eosinophilic esophagitis coming up, And last is neuromuscular diseases. The children who are on the autism spectrum or the special need children, they are at higher risk of putting the things in the mouth which can get stuck in the GI tract. One very, very common thing we need to learn here is these children could be asymptomatic. So having a high suspicion from the parents or the caretakers gives us the clue that the child could have swallowed a foreign body. Well, if the foreign body is in the esophagus, the child may have refusal to eat, painful swallowing, drooling. They can present with some respiratory symptom as the pressure puts on, goes wheezing, stridor, choking, sensation of something stuck, pain in the chest, and later perforation may happen. And if a foreign body with a sharp pointed end reaches the stomach or small intestine, again perforation may happen and the child may have vomiting or feeding refusal. So main thing is history, history, history. Physical examination usually doesn't give us a lot of clues unless it's an advanced case where the perforation may have happened, and then the imaging studies. So let's talk about some of the cases which I have put together. A 10-year-old special need child is having refusal to eat. He's asymptomatic otherwise. He's no vomiting, no difficulty breathing, nothing. And the mother somehow gave us a very good history. And these are all the cases which I have seen in my practice, so I have put them together. Mother reported that the battery is missing from her glucometer. That was the biggest clue we got. Otherwise, a lot of these children, we tend to miss out. A child not eating, we look for the other common reasons. So all the pictures are the original pictures from the patient that we encounter. So I don't know whether we want to make it an interactive section and some of you may want to participate. What needs to be done, I guess, in this case is pretty obvious that the endoscopy needs to be done. Well, prior to the endoscopy, we did a quick X-ray which showed that some foreign body in the form of a battery got impacted in the esophagus. So when we did the endoscopy, we saw that there was, let's play the video also to understand. Since a day or two has gone by with this child, this was the second visit to the hospital. They saw the pediatrician a day before who gave them some PPI and sent them home. And since the child was not improving, they came to us. We suspected, took the child to the OR, was doing the endoscopy. As you see, a lot of necrosis has happened. There is a sloughing of mucosa. The battery was kind of stuck. And this is because it was an active battery. It was actively leaking alkaline current. We see all the necrosis, all the challenges we are facing. There's a lot of sloughing of mucosa. But finally, we were able to grab it and remove it out. So here is finally the success we saw where the battery came out. Now, sometimes when we look on the X-ray, there is a confusion happen whether the child may have swallowed a battery or may have swallowed a coin. The button batteries have a bilaminar structure, making them appear as a double ring on the plain radiograph. The double ring helps to differentiate that this is like a battery, as we can see on the X-ray on the right side. And on the lateral view, the button battery has a step off at the separation, and by contrast, the coins has a sharp, very crisp image. So here is a radiograph where a disc battery got lodged in the esophagus, which was immediately removed with the endoscopy. It's the same child that we have just saw on the endoscopy. I think here we are very, very clear whenever there is a history that the disc battery has been ingested, we need to immediately rush to the hospital and possibly after doing the radiographic evaluation, we will proceed with the endoscopy. There are not many thoughts. Let's move to the second case. An 8-year-old boy was playing with the magnets. He put 2 magnets in his mouth and accidentally swallowed them. Now, child is totally asymptomatic. What do we need to do here? So magnet require urgent evaluation. It all depends on the timing, location, and number of magnets. Now, history can be misleading here. A child may not be able to tell you, a parent may not be able to tell you the how many number of magnets a child may have swallowed. If we are 100% sure, and again, the X-ray can be misleading as well. But if there is a bigger child, they were only playing with one magnet, and that can be managed conservatively because one single magnet is a blunt foreign body object and is usually not gonna cause any harm. However, if there is a one magnet which has been ingested, there's a high risk of complication. What may happen, magnet may get separated. They may be in the different parts of the stomach, intestine, large intestine, and then they start pulling each other, which leads to the perforation, which leads to the further complications. So here are the endoscopic picture. We saw the parents have fed the child because child was asymptomatic, and it's a very common practice. Give them some banana, give them some milk, give them some food. This will help to move the any foreign body forward. But then if we end up doing the endoscopy, this becomes a risk factor for aspiration. So here we see the magnets. We could identify them in the stomach. We saw that there were two magnets stuck to each other and there was a lot of food bolus. So with the due risk, child was intubated. We grab these magnets and we bring them out. So both the magnets we were successfully able to remove and the child stayed asymptomatic throughout and recovered pretty well. So here we grab the magnets from the stomach and slowly pulling them out. We are into the food pipe now. And here we will be able to completely remove them. So there's a picture taken from the web. There's a radiograph of a boy aged 3 years. He has 3 magnets that resulted in volvulus and multiple bowel perforation, and the child ended up getting surgery here. So now this is something, a lot of times I get a call from my fellow pediatrician, the child has swallowed a magnet, so what needs to be done? Well, the basic thing is get an X-ray done, take a good history examination, get a basic X-ray done, and immediately refer to the gastroenterologist. If we are very sure the child has only swallowed one magnet, we can manage it conservatively as we just discussed. But if there are more than one magnet, if it is within the approach where the endoscope can reach, we need to remove it endoscopically. Otherwise, child may need the surgical removal. That can be decided later based on the symptoms and the continuous follow-ups and the X-rays. Sometimes if there is a single foreign body, we also tend to give them some osmotic laxative to flush it out. But multiple magnet, as I just said, needs immediate, child needs to be admitted in the hospital. Do not send this child home. If the magnet or foreign body is in the stomach or in the proximal small intestine, we can remove it endoscopically. If the magnet or foreign body has gone beyond that, then we need to get the serial X-rays. Surgeon needs to be involved, and this child may end up needing surgery. So a 3-year-old child swallowed a quine, our next case. I think this used to be the most common presentation of the foreign body quine, but luckily the children coming with the quines have come down now. I think the one reason could be, especially I can talk about in Bangalore, the people are not using the quines anymore. I think all over the country probably, mostly UPI things are going on, credit cards are going on. So very few people are bringing quine to the home. But this child had dysphagia and vomiting. He was drooling continuously, and the X-ray showed there was a foreign body quine stuck in the upper esophagus. I think again a pretty straightforward case that we need to go in and endoscopically remove the quine. So here when we did the endoscopy, we saw quine was stuck in the upper esophagus. It was a small child, so it took us few seconds to manipulate. And one thing you will see, whenever you try to remove the foreign body, our instrument always align with the foreign body. So we have to rotate it 90 degree, make it good perpendicular, and then just grab the coin. This is a rat tooth forceps, which we use through the side port of endoscope. And we are just holding the coin and will come out. And it was a pretty easy, straightforward case. So this child recovered well. Within few hours, we were able to discharge them. He tolerated the food well. Now, I think this was my most complicated case that I saw. A 15-month-old, very young child. The grandmother was doing some sewing work and the child swallowed 2 needles. Asymptomatic, no symptom at all. The grandmother saw the child putting needles in the mouth. She tried to remove them, but child swallowed them. Parents gave milk and banana. Child swallowed well, asymptomatic, brought to ER after 12 hours. Now, on the right side of the picture, you will see the X-ray where we're seeing the 2 sewing needles, but they unfortunately have crossed the stomach. They were into the second part of the intestine in the jejunum they were stuck. And the left side is a picture from the endoscope. It's a small child, remember, so when we're putting the endoscope, we are inflating the stomach, inflating the intestine, and that is putting pressure on the lungs. So my anesthesia colleague was definitely pondering me that try to finish it soon. I try to move towards the jejunum. Usually our limitation with the upper endoscope is we are only able to go till the second part of duodenum. But here, taking the due risk, we try to advance. However, child started having respiratory compromise, so we have to abandon the procedure even when foreign body was visible to us, but it was so stuck and embedded. It needed a lot of maneuver. The time was not with us, and I could not remove it. The child ended up getting surgery. But here the most important part was the crucial 12 hours were lost. If a child would have been referred to us, probably this foreign body would have been in the stomach and we will be able to remove them, but that was not the case this time. There's another interesting case. I think a teenager, she has to take a tablet, but she forgot to remove it from the wrapper. So she swallowed the tablet with the wrapper. Obviously, she was having some discomfort in the chest and some pain. So the difficulty point was because all the 4 ends of the wrapper were sharp and they could have caused the injury to the patient. But we were very quickly able to grab it and remove it out, and child did pretty well without having any significant symptoms. But otherwise, it may seem it's a blunt object, but because the wrapper has the sharp ends, we end up removing it endoscopically. So again, just a one carry home message. If it is a radio opaque sharp object in the food pipe, urgent removal. In the stomach, again urgent removal. The challenge becomes if it has passed the stomach, it has gone to the small intestine. If a child is symptomatic, we need either enteroscopy, double balloon enteroscopy, or the surgical removal. Or in the case of the asymptomatic child, we can follow clinically. The difficult condition becomes when it's a radiolucent object. If it's a symptomatic or recent ingestion, we can do the endoscopy, but if it is not, maybe a CT scan sometimes help. A non-contrast CT of the chest and abdomen, which should not take more than 10 minutes, can give us the immediate answer to that and help us move forward. Now, another common case I get a lot of referrals for till date, a 2-year-old child accidentally swallowed a coin. Child is asymptomatic. We did the X-ray. The coin is in the stomach. What should we do? Would anyone like to answer here from any of my colleagues? Anyone, sir?
Our gastroenterologist Vishwanathan is here. MSV sir, please your comment, sir.
I think Dr. Arun, yes, I think days are gone when we say that we wait. I won't wait actually. What happens is we have a discussion with the family.
Okay.
The child, there's always a chance that it may not pass through. If it has been there for nearly 24 hours, 48 hours, and in fact, even earlier, then I give an option of, well, I think you could wait, but rather than waiting and sitting and putting leave for your work and then waiting and seeing whether the child is going to pass kind, I'll give the option of removing it because we are having better scores, we have better anesthetists nowadays. So the option will be better go and remove, have a discussion with the family, tell them the benefits of removal and waiting. What is the problem of waiting? My suggestion is to remove it.
That's a pretty.
Also ask for any previous history of any surgeries. All sort of things also matters here. Thank you.
Thank you, sir. Yeah, definitely any previous history of surgeries makes an impact. So now we have the X-ray, coin is in the stomach, child is asymptomatic. Yes, there is a good thought that we can take it out in 24, 48 hours, get rid of any stress, and we don't have to worry about it. But ideally, our guideline says and our clinical practice says we can wait up to 1 month. Yes, that long a time. I have had at least 10 to 15 children who swallowed a coin and they passed within 2 weeks to 3 weeks. On the other hand, I remember I had a child who was coin was sitting in the stomach for 15 days. The family was getting very anxious. We tried to counsel them. They were, no, sir, you do the endoscopy. As we took the child for the endoscopy, we gave the anesthesia, child was intubated. I passed the scope and the X-ray was done 2 hours before the procedure. Coin was nowhere to be seen. With the peristalsis which got induced and the injection ondansetron given, it helps to move the coin and the coin was already past the pylorus where I could not look it. And we got the X-ray done there and showed the coin has moved to the small intestine. So here in an asymptomatic child, we can wait for longer time. We do not have to do the repeated X-ray. We don't have to lose our sleep on that. These are inert objects. Coin is not going to discharge any current or so. So in these cases, unless of course the family is very anxious or the child starts getting symptomatic or there is a past surgical history, as Dr. Vishwanath said, we can wait. Here I put an endoscopy of a child whose coin was sitting for more than a month. So we did the endoscopy. The endoscope is going in now. We are intubating into the esophagus. We are still in the upper part. So as we...
Sorry to disturb you. I
Please.
just wanted to ask, otherwise, after 15 minutes, I'll reach somewhere else. Should I go there and take? Will you take another
Welcome.
15 minutes?
Ma'am, well, good evening, first of all. I'll take about 5 to 7 minutes.
Right. I'm actually somewhere out and they wanted to close the place.
Ma'am, not a problem. I mean,
Welcome,
we'll
madam.
have our questions to Dr. Arun, so you can probably go and then it might be better for you also.
Anyway,
Is that
we are
okay,
very
ma'am?
happy to welcome you, madam.
So,
In
thank
spite
you.
of
very
our-
happy.
I've been
You are
seeing his
joined us.
cases. I didn't want to disturb, but 15 minutes, if you people are going to
Yeah,
be,
yeah, yeah. We'll
Yeah, we
keep
will
ourselves
wait,
engaged,
madam.
ma'am.
I'll go
Yes,
to
ma'am.
hospital then.
We'll
Okay.
Yeah, we
wait,
will
madam.
wait for
We'll
you,
wait.
ma'am. Thank you.
We'll wait for
Thank
you.
you, thank you.
Thank you, ma'am.
Sorry for the interruption, sir. You
No
proceed,
problem,
sir.
sir.
Proceed,
No
sir.
problem. I think we
Proceed,
are in the middle of some interactive cases here. So next child, we have a 15-year-old girl with anorexia nervosa who was trying to induce vomiting with the toothbrush, but she accidentally swallowed the toothbrush. Now the child is asymptomatic and my x-rays did not help me because this is not a radio-opaque object. So what should we do in these kind of cases? Should we go ahead and remove it endoscopically, or we know that this doesn't have a sharp object? Child is asymptomatic, is a big girl, we can wait and watch. Here this number 5 centimeter is very important. Any blunt object even which is more than 5 centimeter, they usually get stuck either in the pylorus or somewhere in the ileocecal area. So where they need further intervention to get them removed. Now, a lot of times, not only this toothbrush, some toys, some spoons, the parents come to us, a child has swallowed some foreign body which is not sharp, but which is less than 5 centimeter. Usually we can wait. If it is with that's basically a rough criteria. We have to look for the symptoms. We have to look for the other things, as Dr. Vishwanath said, the surgical history or so. But in this case, we knew the toothbrush was a bigger object. So we went in and we did the endoscopy and removed it. Now, this is another interesting case I have put in here when I was doing my fellowship. There were two twins who were playing in the house, about 5, 6 years old, and we know that the kids tends to lock each other in the closet. So the one twin locked the other twin in the closet, and now she was thinking where to keep the key safely. So she ended up swallowing it. Of course, the twin which was locked up, the families broke the closet and took her out. But the one who swallowed the big key, and it was a big key, it was like 6, 7 centimeter special key which the child has swallowed. So we removed it endoscopically, as we can see the end of the key here. So this key was grabbed and removed with the objects. So these are some of the devices we use to retrieve the foreign bodies. On the left top side is the rat tooth forceps. Left lower side is the Roth net. Again, you can see the right bottom side, there are some pictures depending upon what kind of the foreign body, whether we're using a basket, a net, a forceps, kind of the object. So when we have to act urgently, and I think some of the part has been covered about it, when the object is sharp, it's more than 5 centimeter, has magnets, battery, it is stuck in the esophagus, we need to remove. This battery, absolute emergency, don't waste any minute. This is the one thing which I will ask the hospital if they call me. You shift the child to the OR. I'm flying from my home. Don't waste any time. The anesthesia should be in the room when I reach it. Any airway compromise obviously needs an immediate attention. Any obstruction? See, this is an urgency, not a true emergency. Yes, child is uncomfortable, maybe drooling, showing some anxiety signs, but we can still wait up to 24 hours in such cases. For example, if a coin got stuck in the upper esophagus. If there are signs suggesting intestinal obstruction, any fever, abdominal pain, vomiting, it needs to be immediately addressed. And as I said, the suspected ingestion occurred in more than 24 hours. And if it is in the esophagus, then it becomes towards the emergency that we need to do. Well, always keep in mind, children may be asymptomatic. The initial evaluation should include X-rays, both anterior-posterior and lateral of neck, chest, and abdomen. All three areas should be involved. And sometimes it's an urgency and sometimes real emergency, especially when there are sharp objects, batteries. And any patient with a suspected foreign body should immediately be referred to a pediatric gastroenterology for further evaluation and follow-up. Here are some of the pictures of the foreign bodies we have removed. On the left side, first picture is an open safety pin. Here the challenge was first we have to close it within the stomach and then pull it out. So that took some skill. On the left side bottom, a child has swallowed the multiple screws, sharp end, they were in the stomach, and moreover then the family fed the child with all the common things of bananas and so. On the right side upper, another sharp object was swallowed by a 2-year-old child with a pointed end. Then on the bottom, we have our common coins, magnets, these things. Well, that X-ray needs a special discussion, but maybe not today, some other time. Well, anyone want to comment on this X-ray? This is my last slide, by the way.
It's looking like a bottle, sir.
Yes, and where it is?
Almost in the large
I
intestine
think
or
it's from the rectal, through the
rectal area.
Exactly. So this is a 18, 19-year-old who got drunk and he inserted a beer bottle from the rectum.
Ayyo. Oh God. But did you
Thank you
remove
very
it, sir?
much, sir.
Did you get to remove it?
Yes, though, but this was 18, 19-year-old, so not exactly my case, but yes, this was removed.
Okay.
Wonderful presentation, Arun sir. Really very
Thank you,
practical.
sir.
And
Thank you,
our
sir. Very nice
students
presentation,
who has
sir.
joined in YouTube will be benefited.
Thank you, sir.
Thank you. Before that, we acknowledge the presence of national faculties like Subodh Gupta and our Amul Pawar and others also have joined. Welcome,
Yeah.
all of them.
Yeah, well, Dr. Neelam Mohan, Madam joins and we welcome the national faculties. Can we take up the questions, Dr.
Yeah,
Tirumurugan, sir?
I think
I think
we'll take up the
yes.
questions once Madam is ready. We can
Yeah,
start.
yeah. We have the
Yeah.
first question is what is the extent of upper gastrointestinal tract that the upper GI scope can evaluate? I think sir already hinted about it. Sir, can you elaborate on that, sir?
Yes, ma'am. So, ma'am, usually we are safely able to reach till the second part of duodenum.
Yeah.
Now, with little of our maneuvers, we can reach till the end of the duodenum and beginning of jejunum, but that is where the limitations of the upper endoscope ends. Suppose there is a foreign body and we have to go further. There is a newer scope called as double balloon enteroscope, which we can use, and that help us to grab the foreign bodies even little bit into the ileum as well.
Oh, that is really nice to know that. And only Ashwat sir can ask, but I was also thinking about can we use a magnet in the scope to retrieve a metallic foreign bodies?
No, ma'am, because we have to look at the path, and if we accidentally drop the magnet, that becomes another risk factor. We have some pretty nice equipments to grab the metallic foreign body and safely take it out. So I believe, I don't know whether the doctors have previously tried it or not, but as of now, we are not using any magnets to remove metallic objects. I showed one of the pictures, we have some pretty good forceps and nets to grab the metallic object.
I'm not sure. Is he asking about the precautions taken during magnet removal, or it is this magnet is Ashwat talking about which you may be using? I think he's asking about the precautions will you take when you're removing a magnet.
Okay, again, we have, as I said, we have some really good nets that we can use. They are pretty fine nets, and once we get a good grip over the magnets doesn't skip out. Unless it's really a pinhead size of a magnet, the magnets does not skip out of it. So we are pretty safe with the instruments that we have. And I think these are the latest modification that we see at this time.
Oh, Ashwat sir wanted whether to know that using the magnet therapeutically, which you have said that we are not going to use because of certain side effects.
Yes,
So
ma'am.
that's yeah. So is Ramachandran sir, our professor has asked, is sucralfate more easily available and quality assured compared to honey, a good alternative to honey for BB injection as first aid?
So yes, sucralfate is easily available, but again, when we have a child with the foreign body and we are planning to get the endoscopy done, we want to keep the child NPO as many hours as we can. I mean, from 6 to 8 hours if we can get that window, because otherwise they are at risk of vomiting and aspiration. We always intubate these children to prevent this risk also, but again, micro aspirations can happen. So we do not want to give anything ideally to be fed to the child. So whether honey or sucralfate, or as I said, a lot of patients come when they have given the banana to the child. We definitely discourage that. It becomes a nightmare for us. And moreover, sucralfate is gonna coat the esophagus or into the stomach also, which makes our life difficult because most of the time child is not NPO, they have some food in the stomach, and it becomes a nightmare to keep picking. A lot of times these endoscopy, which are 10-minute procedure, has taken me 2 hours because we have to remove the food first and in a very, very small pieces. So we ideally do not recommend giving sucralfate.
So should we routinely get a gastroenterologist opinion if we see the coin and the level of the duodenum or in the stomach, or we can wait?
No, ma'am. As I said, the child expectedly will be asymptomatic and we can
Yeah.
wait for 1 month, which is a pretty long window. Yes, after few days, if family is very anxious, or sometime I say pediatrician is very anxious, our colleagues get anxious, you can always send to the gastroenterologist to keep them in the loop. But immediate endoscopy is not required in most
And,
cases.
and how much about the usage of routine laxatives for all the cases of foreign body ingestion, sir?
Again, if it is a blunt object and the child has some constipation or some difficulty in the passing stool, we do use. Obviously, for the foreign, any sharp objects, we are not going to give them any laxative here. The goal is to remove or with the button batteries or with the multiple magnets. So routinely, we only can use a laxative if it is a blunt object. For example, a part of the toy has been swallowed.
Okay. Thank you so much, sir. I think Dr. Tirumurugan, sir, any questions in the YouTube or
I
any
think
comments?
that is, sir, what are the contraindications for endoscopy?
Perforation? Any complication?
Contraindications. We
Sir,
have
if
talked
the
a lot about the
child has
indications.
already got the perforation done, that
Okay.
we do not do. If we know that the foreign body is beyond the grasp, if it has crossed the duodenum, even if it is a sharp object, then the surgical colleagues will need to step in and they do the things. And the third is one example which I showed, a sharp object which was in the somewhere in the duodenum. So we could not remove it as is a pretty young 15-month-old child. But main contraindication is perforation if the object is beyond the reach of the medical gastroenterologist.
And is the age a contraindication, like the younger, the smallest child? How young would you go consider doing
So here the challenge
endoscopy?
is the scope we get usually in India. I have used in the 1 year plus child. A couple of times I had even the younger child whom I need to do endoscopy. Here I also involved my ENT colleague because their scope is very thin and small. Though it's not the ideal scope for us to use, it's very flexible. It doesn't give us the good pictures, and even with the millimeters change in the direction, the whole view changes. But sometimes, as I said, in less than 1 year old, I have used couple of times. But 1 year plus, I have safely used the regular endoscope that we use.
Thank you, sir.
So, can we have some expert comments by MSV, sir, and while we wait for madam?
Yeah,
On
just-
this topic as well as the next one. Yeah.
Vote MSV.
Yeah, thank you. Few things, Arun, thank you. You just
I think
covered.
Madam has joined.
Yeah.
Got most of the things. Thank you. Few
Thank you,
things.
sir.
Usually, when we refer the patients to the pediatric gastroenterologist, please do. If they have a similar thing, foreign body, ask them to bring it. Sometimes what happens? No, sometimes we have to do a rehearsal outside because sometimes I've seen children who has taken AAA batteries. So you'll be surprised. They can swallow anything under the sun, and so sometimes the accesses we have will not be useful to take it out. So what happened for this particular child, I have to wait for my adult colleagues to send a correct accessory, which is called the trapezoid forceps. We have to use that one to take it out. There is no point in going in and then not able to take it out with the accessory we have. The Rothnet, the snares, the forceps, they're all useful. But
Right.
sometimes we have strange foreign bodies for which we have to use something which you have to rehearse and then we go in. That's one thing. And second thing is, as Dr. Arun mentioned, this giving all this food is not only going to be anesthetic risk, but also it just obscures our view. I remember a child, when you give a foreign body banana, it's not useful. They're going to refer the child for endoscopy removal. I saw this foreign body before I went in the X-ray. When I went in, I couldn't see the foreign body. Basically, the bananas engulfed the kind. I couldn't see. We have to peel the banana before you actually get into the foreign body. That's another problem. So better not to give this food. It's not going to be helpful at all. And third thing is, always check the development of the child. Autistic child is not only about the foreign body, they'll be taking the hairs, coils, they will have a bizarre also. There's another thing which I've noticed apart from the usual foreign body. Even though there could be a radiolucent, they might have said that it's always better to take an X-ray. You'll have surprises. I have seen a child who has taken a radiolucent body and also has seen a button bladder in the pelvis. The child was playing in the toy shop of these parents who are having toys. So it's always better to take an X-ray before we go and remove that. And third thing is, if there is a suspicion of a foreign body getting stuck here for a longer period of time, before we do an endoscopy, we also do CT scan. Sometimes we have to check whether it's an impaction, perforation, particularly delayed presentation. So it's very important all we do that before we do this. Another important thing, the guidelines, which we say that you wait for 1 month. Ideally, if it is your child, you will not wait for 1 month, honestly. These are the guidelines coming from American societies or the North American societies where the care is done by the government services. They want to prioritize the government care all the time. Here in our setup, when they come to a private hospital, always have an option, discuss with them. If a foreign body is not going to pass in 24 hours, 48 hours, it's going to be there for some more time. So discuss the pros and cons. They're willing because it's very safe to remove it nowadays rather than waiting for a long period of time. Another important thing is small keys. People say that keys we wait. No, I had a child in a ring, the 3 or 4 keys. The keys has passed the duodenum, but it cannot come out ileocecal valve because when one key has come out, the other key could not come out because the ring is in such a way that the angulation is there. So all these things matters. It individualized. Everything has to be individualized. Sometimes we have to remove them before they get into the problem. 95%, 96% of the time we sort it out. Hardly we need a pediatric surgeon help unless it's a very significant foreign body. Even the shafts, we can put over the scope one, we can just grab it in a safe way. All those things there, sometimes we have to have the help of adult colleagues who have more experience also. Thank you.
Thank you, Dr. MSV, sir, for your expert opinion, and Dr. Arun for his eloquent and talks. The videos were so very clear. So while I think Dr. Tirumurugan, Dr. Neelam Mohan has joined, no?
Madam has joined. I think if she's ready.
We can, yeah.
Madam is joining. She's just in the
I
link.
was all the time here only. I didn't go at all.
Yeah, thank
Because
you,
I'm
madam.
Okay, ma'am,
Thank you,
please
madam.
take over,
In
ma'am. The
spite
stage
of-
is yours.
in spite
I
of-
thought I was just not being seen, but I'm in
Yeah,
the car.
Madam, I request our president, Rajendran, to formally welcome you,
Yeah.
madam. Over to Rajendran. Sir, Rajendran, sir, please.
Sir, you can welcome her, ma'am. Rajan sir is there, but I think.
Yeah, doctor. Yeah, we are.
You do.
He's driving. He's just
Yeah,
driving
it's-
from the
Probably he'll
hospital.
be driving. Yeah.
Yeah, it's
Over to Narmada, you welcome.
Good evening, Neelam. Good evening.
a very warm welcome to our president, Dr. Neelam, President-elect Dr. Neelam Mohan, ma'am, who has joined with us for a very interesting session. We all know what a great academician she is, and she has been in the international forums, taking up the important post, and she has represented India in most of the international forums with respect to gastroenterology. And with her vast expertise in hepatic transplants, madam has led the directions for the hepatic transplant in entire India. Now, I know she has a very tight schedule, and she had been traveling up and down Gujarat and many places for the programs here. And so we are very happy to have you amidst us for yet another interesting session of pediatric plunges and for practitioners. So with that, I hand over the forum to Dr. Tirumurugan sir for further adios till madam settles herself comfortably.
Thank you, Dr. Narmada. I think she's just started.
Yeah.
Probably
You
the
can
one
introduce
issue
her.
we
Yeah.
missed out is that Madam is National BC Roy National Award by the
Yes.
Government of India, and it's a real pride for all of us as pediatricians to have somebody like her, one of the very few in the country to achieve that. So welcome, ma'am, and
I think we'll give her some breathing
Yeah,
time.
I'm in the left.
Yeah. While we are at it,
Yeah,
I
yeah.
think that we have Dr. Srinivasan sir and PRC sir joining. Sir, I really wanted to ask how much of our expertise in the institute, it might be easy to do it, but any thing from the private practice where they referred late or they took time or they had issues, can you please share your experiences, Dr. Srinivasan sir and PRC sir?
I was never in private. I was only in government service.
No, but
And,
some cases you would have dealt with where they had issues, no, sir?
No. I think everything has been covered, so there's nothing new to
Yeah.
this thing. I think Ramachandran PRC, who is still attending Ramachandran Medical College, can share his views.
Yeah, PRC, sir.
We have it's probably around 2 decades ago in 2009 or 2000. That time we had some problems with the button battery injection. At the time, the awareness regarding the importance of removing the as much reducing the delay was not this much. So there have been inadvertent. Sometimes there have been a delay with a lot of complications like mediastinal perforation and mediastinitis. Such kind of problems we encountered in those days because button battery was something which was new. So both the diagnosis as well as the need for without delay removal was not very good. So that is the time we had some initially 1 or 2 cases we had some problem. Then everybody became very alert regarding the identification as well as the importance of immediate removal.
Yes.
And of course, children have a tendency to put it anywhere. It is not only the digestive, also it is a aerodigestive. So
I know.
they put it in the nose, they
Yeah,
put it in
totally.
the ear. So anywhere it can, once it gets lodged, it can cause, give rise to problems.
As a
So,
private practitioner, it's a nightmare for us, sir, because they come in the night
and
and
yeah,
Narmada,
Yes,
is
ma'am.
my PPT shared? Is it showing?
Yes,
Yes,
madam.
madam.
But we need a
Yes,
slideshow
madam.
presentation.
Yeah, I'll
Slideshow.
just go into slideshow.
Yeah, ma'am.
Thank you, madam. We are
Thank you,
really
ma'am.
honored
Okay.
in spite of your
Okay, let's
busy
get down
schedule.
to work.
Yes. Yeah. Okay.
I heard every discussion quick. Actually, even internationally, nobody says a month. I think guidelines are 1 week. But I agree with Vishwanath, the size of the coins of Indian coins, if you see, their coins are 2.2 millimeter less. All Indian coins are very big. So their rule doesn't, because if you go and measure all 50 paisa, 1 paisa, 1 rupee, 2 rupee, our coins are big. So if you go in intricate guidelines, they have those cents and all which are small. All of you have traveled to USA. So therefore the guidelines have changed and we're working to come out with the other guidelines, and that should be out soon. Anyway, coming down to work, can you pin me, Narmada,
Yes, ma'am.
so that I can remove the others?
Yes. I think Dr. Tirumurugan, sir, can you ping Dr. Neelamon, ma'am?
And
Yeah, I have done that.
Yeah, ma'am, the stage is yours.
but I can see so many people. I don't want to see so many. Yeah, now I'm better.
Yeah.
Okay. So this is a very crisp talk for the pediatricians, and I made it for the first time. Instead of giving commandments in a particular subject, overall in liver disease, how you should take care of this. So typically one case and a commandment. Newborn baby was normal antenatal birth order 1. This mother was a little elderly, 37, 38 years old, and normal vaginal deli in a very prime hospital in Delhi with a good birth weight. And baseline test, which happens in newborn screening, everything was okay. She was probably had phototherapy for a day or so, she said, and she was discharged. She went almost till 6 weeks to a doctor, and he was checking with bilirubinometer, and he checked with the bilirubinometer. She was worried, why is it still, around 9? He said, no, it can happen, and that's what. But this child was related to one of the surgeons who told them to meet me. And that's how the child landed up to me at 57 days of life. And the baby was, good weight, active, liver, 3.5, this. But the color of when I changed the diaper, I looked, this really scared me. And I was worried, and I knew there was a big mistake done by the doctor. The mistake that the doctor did was he used a bilirubinometer. So he did not check actually the direct bilirubin. And the conjugated cholestasis is anything where the direct bilirubin is more than 1.5. You would have a dark urine, but the clay stools are not must. They may or may not be. I was lucky this child was having clay stool, because in biliary atresia usually you get clay, but in all patients of cholestasis you may not get clay. So I did urgent investigations. I told them you should see me within 3-4 hours by evening, and the investigations were 9.6 by 7. As you can see, LFT is deranged, and I was normal. Ultrasound, nothing great. All that it was commented was a contracted gallbladder. And so the diagnosis was neonatal cholestasis. So the first thing that you should come in your mind in a well baby who's active, growing well, and going to the doctor with a cholestasis, first thing that will come to your mind is biliary atresia. So the next day itself, I did the biopsy in the morning by 9, and the biopsy's report was available by 5 p.m. In our institute, if we do it in the morning before 11, we give the same day. So that was biliary atresia. And in biliary atresia, you need Roux-en-Y. But the earlier you do, the better the results. Like you can see in 30 days, the results are even better than in 60 days. I would have loved if you people start referring as early as, a month. That will be great. So it took some time. So you can see it took 3 months for the baby's bilirubin to settle. And the baby is doing very well. And I saw last month I didn't enter that report. So a timely Kasai surgery could avoid a transplant. So my commandment number 1, thou shall not ignore prolonged neonatal jaundice. Any jaundice beyond 2 weeks, please do total bilirubin and direct bilirubin. Please work to ensure you think all cholestasis for you should be biliary atresia. It is our headache if it doesn't turn out to be. Unless proved otherwise, you should think it to be biliary atresia, because Kasai surgery timely can be life-saving. Another child, 4.5 years old, and presented with abnormal liver enzymes. You can see 298, 377. So many times the child was going for almost 8-9 months to the pediatricians with abnormal liver enzyme. But I wish the pediatrician could have been very vigilant, because I identified a little hypertrophy. I thought there were no family history, but the genetic turned out to be Becker's dystrophy or a Duchenne muscular dystrophy. So because a good little clinical clue and nothing else was positive in that child. And so the commandment number 2 is transaminases is a clue to the diagnosis. We say that if AST is raised, it is usually muscle or hemolysis, but it could be Wilson's disease, it could be fatty liver disease, it could be alcoholic liver disease if older. ALT is typically more when your parenchyma is affected, or so like viral hepatitis, etc. And GGT is raised in cholestatic disorders typically. So these are indirect clues. So your commandment was, please, thou shalt check the liver enzymes wisely. Close to 8 months, 8 years, this child comes to me with pain abdomen for 2 weeks with, loss of appetite initially. They were not sure that the child looked jaundiced, but the child had altered sensorium for a day. They were right because bilirubin was around 3. Sometimes it takes bilirubin to be 3 to be detected clinically for the parents. They may not see it before that. And the enzymes were not very high, but if you see the INR was 3.3 and an albumin was 3. So this is fitting into the diagnosis of acute liver failure or acute on chronic, we don't know, but INR is deranged, it is liver failure. So the commandment number 3 is, thou shalt respect the silent rise of synthetic dysfunction. And if your INR is raised, then it is more specific that the liver is conking off than your liver enzymes, because there may not be much in the liver. Most of them would have got necrosed, because this child is coming to me 2 weeks. Was there an underlying CLD? Part 2 of the story, but that was just an alert that thou should take care of INR, which is very important to see as the synthetic and not just get impressed with the liver enzymes only. Case number 4, the child had fever and jaundice for 1 day, but extremely important for thou to take a good history, because there were 2 past history of jaundice in the past. And if there is 2, this, like, liver was 2 and the spleen was around 2.5 to 3. Growth was okay based on the parent's height. Her height was okay and her weight was on the 50th centile. This was the bilirubin 3.7 with liver enzymes 150, 190. But 9 months back, they were quite deranged. And the doctor told them, earlier he had said that it was probably drug-induced. And then he said maybe non-specific viruses, because he did hepatitis A and E, it was negative. But thou should always think about chronic liver disease, because in this case, when we investigated further, it was autoimmune liver disease on liver biopsy, and it was already cirrhosis. So your commandment is, thou shalt think beyond hepatitis A and E, because he kept thinking, oh, it is not this, it could be. So any recurrent hepatitis, think about chronic liver disease, drug-induced or whatever, think about that and do investigate and refer the patient to a specialist to investigate. 9 months old came with jaundice and started beyond 2 months of age. So the liver enzymes were increased, as you can see, but everything that is there, cholestasis need not be biliary atresia, it could be other condition. In this case, the hint was a low GGT. That GGT low could be a PFIC or a BRIC or a bile acid synthetic disorder, and the liver biopsy was suggestive of intracanalicular and intrahepatic cholestasis. We need to do genes because, type 1 may have other system involvement before you go for the transplant, because you can do early cases biliary diversion. So it gets important to do the biopsy as well as genetics. So commandment number 5, thou shalt be vigilant for genetic and metabolic liver diseases, especially in infants and toddlers. You have to think about more metabolic diseases, and always good to take a specialist help at early so that you have it on your radar, the metabolic liver diseases. 10 years old who presented with pain, and his weight was 97 centile, and though he had acanthosis and central obesity, but his liver enzymes continued to be abnormal. So there is nothing that just because you're fat, you need not have Wilson's or autoimmune. You can still have something else. Every fat person cannot be a fatty liver. So I waited for 3-4 months, but the liver enzymes were not settling, and the ANA titer was high. ANA usually seen in autoimmune liver disease. It was 1 in 80. It was not obnoxiously high, but it was high. And when we did the liver biopsy, it was 3/4 liver fibrosis, but it was actually fatty liver disease, which we now call as MASL, MASLE, which is metabolic associated steatotic liver disease. It was FibroScan which made me go towards the biopsy, because FibroScan KPA was 7.6, that suggests fibrosis. So because of that and autoimmune, I thought I should not really think about fatty, I should go, and it turned out. So another message to you is, as early as 10 years, also fatty liver disease can have extensive fibrosis, and a good medical management with some drugs and weight loss and a lifestyle. In 6 months, we could make him reduce around 20 kgs in 6 months, and he improved quite a lot in his there. But sometimes, like I did biopsy, but in this case, 60 days with jaundice, dark urine, clay stool. So I said, think always of biliary atresia, but typically this was also liver, spleen, and liver enzymes, PAs. Ultrasound, same non-excretory, contracted like my first case. In my first case, I didn't go for biliary atresia, HIDA, because already the child was 58 days. I didn't want to spend 5 days first trying to give phenobarbital and then doing. And that's why we went. In this case, the child had a HIDA scan from outside and was 60 days, but my biopsy was suggestive of neonatal hepatitis. But I don't need to do biopsies every time. Like this face is allergy, so I know it is allergy. I did not do. The second case was a liver cholestasis, but there was a skin rash, and biopsy showed me LCH. So, LCH, sclerosing cholangitis. So commandment number 6, thou shalt know when to do a liver biopsy and when not to do. Biopsy is valuable, but not always necessary. In the last 2 cases, I showed you LCH or allergies. Without a biopsy too, I could come to a diagnosis. So we do have some indications, and we do have but you should avoid biopsy if there's uncontrolled coagulopathy or there is an ALF with encephalopathy. And in this case, you can see the child has had biliary atresia casi. There's a scar on the skin in that case. But look, the doctor waited till the child was so bad before referring me for liver transplant. There is clubbing, there is so advanced liver disease. So if the bilirubin does not settle, commandment number 7, thou shalt not consider transplant as a last resort. It's a timely option. You need to refer to a transplant center when the bilirubin does not settle within 3 months. You should not wait for that, because we need to look at the growth, nutrition, extra part before we consider a liver transplant. 11 years old girl who came had pain abdomen and was not growing weight and height. As you can see, she was just 24 kgs with a height of 129 centimeters at 11 years. and the liver was just around 3 centimeters. She earlier at 4 years of age, she had that was diagnosed as Crohn's disease on the basis of a biopsy which suggested focal active colitis. And they said she was Crohn, and but she wasn't doing great. Her ESR was just around 12 with a hemoglobin of 10. Her liver enzymes were not enlarged, so I didn't know what was going around. Nothing else was coming normal. And when we did a genetic, it turned out to be hereditary fructose intolerance. And then I checked with a challenge test, and it was positive for hereditary fructose test. So the commandment number 8 is thou shalt suspect liver disease even in atypical situation. In this case, there was hepatomegaly, failure to thrive. No, do not so much liver enzymes at that time. Maybe there are ups and downs that we see. So failure to thrive, developmental delay, prolonged jaundice, unexplained coagulopathy. Do think of liver disease in children and high index of suspicion even when they were very non-specific. And to come to my last case, a 13 years old child who had mild icterus and, liver enzymes were 314, 425, INR was normal, and but the IgG was quite significantly raised, and the liver biopsy was suggestive of advanced fibrosis with 3/6 fibrosis. And these are the cases thou should educate and should refer to, because our responsibility also is a long-term care to talk about the nutrition, medication, compliance, vaccination. It's not just autoimmune liver disease, and I should forget. So in chronic liver disease, our responsibility gets much more to look into all the other aspects in the patient in that. And the last commandment is you have to promote prevention and advocacy for liver. Universal hepatitis B vaccination, safe transfusion practices, genetic counseling when you identify one person in the family to look for the other. Public awareness on the liver health is equally important. Your advocacy for newborn screening programs when it comes to early identification of cholestatic jaundice and others becomes equally important. And we know that 28th July is the World Hepatitis Day, and there's never a day, never a year where I'm not approached by the media. I'm very blessed, media girl, as people call me. And I've written an article in Outlook, which will be across India, hopefully. And you must look for this article where I've talked about the burden of hepatitis B globally and in India. And the theme for this year is, let's break it down. Let's break it down. I meant, let's break down our reservations and our, unless you test, you will not know. There is a burden of 35 to 40 million people with hepatitis B in India, and 6 to 12 million with hepatitis C in there. And during COVID, we had a disaster because we missed vaccines. So it is your responsibility to all those children who are coming to you. Maybe not a bad idea, but even for adults who have not been vaccinated and, in their time, and you don't think. So please get tested, get vaccinated. Those who are professionals need to keep their antibody levels above 10 or 100. Otherwise, we know that the memory is good. We don't suggest booster to everybody except our professionals. Regular health checkups, otherwise you will not understand fatty liver and hepatitis, even if you think. And safe injection practices, these are something which you should not forget. And thank you. We have a good training program, and all those who are interested, youngsters may come to us and follow me to see. I'm very happy to share that my sugar and fat liver got 1 million views on social media. And I need you to follow, because in the coming year, whatever, we are able to send each other, we can forward and do it. So that's what I have to say. Thank you for calling me over.
Wow, that was really amazing, ma'am. It was instead of a 2020, I called 10 by 10, like a cricket match. It went on.
Yeah, that's all. So those are cases were just like to give you, but the commandments were what I wanted to put
Yeah.
across to you all.
Really nice, ma'am. Really very, very nice and very short and crisp. And it is easier for our practitioners to remember also. So having said that, we have a couple of questions, ma'am. What is the medical management of asymptomatic cholelithiasis? And when is the surgery advised?
Okay, so cholelithiasis in asymptomatic, it has been a debate, and a lot of people, even surgeons, believe that there is no point going in for that. However, as a physician, I want to know, why did they get cholelithiasis? So it is extremely important for you to complete your workup, to do your hemolytic workup, Wilson T workup, celiac disease workup, other lipid profile, everything, and do not miss why the patient got cholelithiasis, the lifestyle, did they, did they not eat a balanced diet? Did they not take enough fat? Did they not take enough liquid? Beside all the rattle that I said for the test. And right now, the dictum is, if the patient is not symptomatic, you need not go for this thing. When it goes into the adolescent or adult, that is the time that you have to talk to them. Like, yes, especially for women, we have been telling about the fatty women, 40s, and there is a theoretical risk of gallbladder cancer. So even like me, I was 29 when I just did an incidental ultrasound and I had a gallstone. And I mean, I had an accident. So for that accident, routinely it was done and it turned out to be a gallstone. But the next opportunity, there was a rocky leave, and on the leave, I did my this thing, because obviously I had age in hand and I didn't want to be carrying a gallstone for long, because later on there is a risk about pancreatitis or a CVD stone, say, and that is what. And in my vast practice of 2.5 decades as a consultant, and maybe 30 years since I got into this field as a resident too, and I did see 5 or 7 patients with CVD stone who came to me with pain, and so they never came to me with when it was in the gallbladder, but theoretically they can have. And these patients, one of them was 14 months. So we went in through the liver into the bile duct and removed it, rather than we didn't have scope so small, ERCP going in from bottom. So you do get such scenarios, and that's the.
Yeah, thank you so much, ma'am. Of course, this Dr. Ashwat asked about what is a fibroscan and the rule in cirrhosis, and Dr. Nandini has answered it, but we want your inputs
Great.
on the same.
So basically, fibroscan is also quite observer dependent, just like an ultrasound. Fibroscan is nothing but an ultrasound. So it also believes in that shear. Shear is like, like in the ultrasound waves that they are going and you give you. So in a fibroscan, we look at the time taken and the resistance that the liver is going to get. So it tells you about fibrosis, it tells you about steatosis. So when I showed in my case that normally the CPA should have, KPA should have been less than 6, and the fibroscan showed that there was fibrosis. So nowadays we don't do biopsies for all hepatitis B and C. We do fibroscans. We do in them so you have to have a small probe when you're using for children. The bigger probe, which is for the adults, and there's one obese probe in them for adults too. So if a child is above 6-8 years, you can use the other probe. But other children, you might have to use different probes. So when you use fibroscan, it is observer dependent. What I meant was you need to be sure whom you're sending it to. Maybe an adult who's been doing it may not be very well versed, but you look at it non-invasive way. From the lateral side, you put the probe, in the intercostal space, and that's how the reading has to be consistent. And you look at the average value that they have to be consistent. It should not be a 1 level here, 1 level here. That means they were not very consistent. So otherwise, they're very reliable in telling you and my paper is going for publication. Please read about the fatty liver and the fibroscan and the liver biopsy I did in those children, and it's one of its first kind in India, and not to Indian pediatrics. It should be.
Yeah, ma'am. I think it's a new concept, and Indian Association of Radiologists (IRA) is also taking a great interest in sensitizing the entire pediatricians and the adult for the fibroscans. And we have a couple of very good centers, even in Vellore, who report it only with the value and request us to give that. So, having said that, we'll just pass on to the next just a topic on how frequently do you see the Wilson disease in children and the diagnostics test which you could do.
Wilson's disease is the commonest metabolic liver disorder in India. And in my entire data, I accumulated, I had to give a talk somewhere on metabolic liver disease. So at that time, I looked into the data. There were 325 children or something like that. And Wilson's was the commonest I had, followed by the other. Of course, I'm not including if I include PFIC, progressive familial intrahepatic cholestasis, it's a different ball game. But let me put that into the cholestatic basket, though it is genetic. But that was also number 2, and number 1 was Wilson's, and they come to you as they say just like tuberculosis for a pediatrician, Wilson's is for a liver specialist or for a gastroenterologist. It can present to you as an abnormal enzymes, asymptomatic, hepatomegaly, portal hypertension, sibling screening, anything can turn out to be. So, as I said, gallstones. So, Wilson's, you should have a very, or CNS manifestations, hemolysis. So, Wilson's, you need to have a very, you will not be wrong with the cost that it takes to do a celloplasmin as a screening test to do whenever you find something odd in your patient. Like even though patient was, hepatitis A or E, or it was not settling down, or in the patient I showed abnormal enzymes. So we often do Wilson's screening in there.
Yeah, that's really nice, ma'am.
And the commonest cause of acute or chronic liver failure was Wilson's. The commonest cause of liver failure transplant. If I would have done liver transplants in more than 500 plus data, in that 500 plus data, and mind you, I am in authentic Indian data. There are centers now who have been talking about the transplants, but there's 60% international data. So like even in the South, Chennai, they had a huge cohort of PFIC because all of them were referred from Oman and Dubai. So those patients chunk came. So that's how they had highest number of that data. But for me, it is 93% of my transplants are Indian patients. And so for them, more than 27% of our transplants were in liver failure. And in that 27%, viral hepatitis was slightly less than Wilson's disease as so number 1 was Wilson's, ALF, ACLF, and number 2 was viral. And our data was eye-opening data that in hepatitis A, with an excellent management, I have 1:1 nursing and practically 1 doctor for 3 patients, 4 patients. Why I nurse my ALFs and liver transplant, we have a separate doctor on call. We have 6 fellows. So there is 1 fellow who's looking only after the liver patient, besides the ICU fellow who looks after all the ICU patients. So maybe because of that, 84% of hepatitis A induced liver failure in a data of 400 liver failures total, salvage without a transplant. And I think that's a credit to salvage patients without a transplant too, even though you ended up increasing the cost and everything, but if you save them without a transplant, I feel great about it.
Really great, ma'am, and having a data on Indian and contribution to academics.
All the publications are going to come this year. It's all going, and I hope, bless them, that they take little time to accept the data.
Yeah, ma'am. That is really, really essential for us. And it is great to have academicians like you publishing your data so we understand better. Having said that, what is the incidence of NASH in obese children, ma'am? Because
Well,
obesity is
again, my data is one of the authentic data, which is talking about. I just took 150 children of obese, and I looked into the data. So our data was Ashna. It was 45. She presented that data internationally, and she got an award for it. I think it was 45% or 60%, like that, in obese overall. So that's huge. If I take patients with overweight and obese, the incidence of fatty liver disease was that high. And worldwide, it says, so I'm not really sure, she's around 40% or 44% were with fatty liver disease, had fatty liver disease and obesity and overweight.
Ma'am, I know you are a workaholic, but I didn't know your whole team was like that, working on a Sunday night at 9:30.
No, I
And
came to the hospital, so she's on duty.
I know that, man. The whole, I'm looking at her executive board, how much they're going to work next year. So having said that, I'll just hand over to another workaholic in Tamil
That's a very
Nadu.
good thing. Executive people, all those who are planning to come, Neelam doesn't sleep.
Yeah. Now we have another workaholic similarly, ma'am, Dr. Thirumurugan. I will hand over it to him for
So true.
I
Yes,
know,
yes,
so true,
everybody
right?
knows about him.
Yeah,
He's
so
one
let him
ahead of
get the questions on the
Thank you,
Ultra
ma'am. Thank you.
YouTube, madam. So
Thank you,
any
thank you,
questions?
thank you.
Yeah, please
Thank
take
you,
over.
thank you,
Dr.
ma'am.
Yeah.
Thank you, ma'am.
Hi.
Thank you, ma'am. Just only one or two questions. One is about, see, there was a lot of interest about what about the investigation of a unconjugated hyperbilirubinemia in a child, let us say at 1 month or so.
Yeah, so usually in 1 month, unconjugated jaundice, only from a hepatology point of view, what is going to be, see, I assume by then you would have done your thyroid, and sometimes you can have even a breast milk jaundice, but in breast milk jaundice, the diagnostic test is that 48 hours. But having said that, the guidelines usually say that we should not scare the mother about it. So it's better to look into the other causes, look out hemolysis, rule out thyroid, rule out G6PD, rule out all that hemolysis. And even sometimes I say galactosemia, rule that out. Then you're going for, from our point of view, I would think about Preglanada too. So that would be one condition where I would either give phenobarbital and see whether it responds to that or not. And if it continues beyond a month or so and gets high to the extent of needing phototherapy, please do not miss Preglanada. I had 7 days back a child who came to me and felt terrible about it. Terrible. The child was 47 days or 49, something like this. And hello?
Yeah, ma'am.
Yeah,
I don't know, I can't see myself. Okay. So that was 49 days, and the child had a bilirubin which was so high. And they thought Preglanada, but they did not guide that you should continue to be doing phototherapy. I mean, I can't even transplant, I can't do anything because the child was already eyes up and connectedness, and so bad it was. So you should not miss such cases.
True. I think your two commandments to come as a flyer, madam, for everybody.
Thank you, ma'am. One more question, ma'am. How long, I mean, because most of the guidelines for newborn jaundice, they talk about only about 10 days, whereas you are talking about phototherapy well beyond also. So how long you would advise phototherapy in a newborn?
My battery is conking out. There's 2 minutes.
Okay.
So in case it conks out battery, thank you very much for having me over. Tamil Nadu people are extremely academic, and I look forward to great academic events with you all in the coming year too. And I need all of you to be working in this with me for academically. And All those who are interested, just shout and reach me. Don't expect me to be reaching you all. Please reach me. Show me your field of interest. There.
Sure. I
think I'll join through the WhatsApp and just take the last question.
Yeah. So while we are waiting for ma'am to take up the last, any other queries or any comments from senior Dr. Balashankar sir, over to you.
Madam, good evening, madam.
Good evening, sir.
There is a comment always in Tamil, what you say, nachchen irundhathu. That's on the target. Okay.
Yeah, so the
You were
last
just striking on the target, was very crisp and clear.
Clear.
That's the only thing. I got learned something because one important thing you told, acute liver cell failure is diagnosed only by looking at the synthetic function of the liver, not on the enzymes. So one important point I learned definitely. And number two, recurrent jaundice is almost always chronic hepatitis. Two important things I have learned today, madam, from you. I have got one doubt from your thing. As far
Sir, 1 minute, sir. She wants to answer the question, I think.
No. I said also remember that 10 was advocacy and also as a pediatrician, you need to look into that.
Oh, okay.
Okay.
Okay,
Only
definitely.
one comment. Congenital fructose intolerance, you mentioned in one case.
Very
To my
rare.
knowledge, congenital fructose intolerance was a newborn disease which presents something like a galactosemia, but you told it in an older child. I do not
That's
know
what
so
I
many
want
genetic
to
mutations
say.
have come
I
and.
said atypical.
Madam?
I said atypical.
Atypical. Oh.
And so what happens is all things are a spectrum. The genetic
Everything has become a spectrum now because of genetic
So you
mutations
can
and all.
have variable penetration of that thing. Just like the 5 children of a mother are not the same. Similarly, a genetic problem, everybody may not behave like a copybook picture.
Okay, that's great. Dr. Thiru, you asked the last question, no? But madam was
Thank
just
you, madam.
asking.
Yeah. This is regarding how long would you consider giving phototherapy, ma'am? Because we are talking
Yeah,
about.
so that's what. See, very good question. So what I'm trying to say was, you will have to give phototherapy so that the bilirubin does not go beyond 20. There is no other option. The only cure is a liver transplant. So these people will have to buy the phototherapy machine. Now he's asking me, I'm going to buy, but the child was already connectorous. So you have to give them phototherapy till they buy liver transplant is a cure. What else can I do? I'm talking of type 1. Type 2 is you give phenobarbital, it comes down. But type 1, where the bilirubin is going beyond 20, this child came to me with 33. So you have no other option in that case.
Yeah. Thank you, ma'am. Now we'll have...
Yeah, I need to go home now.
Yeah, I know. Thank you so much for joining us in spite of your busy schedule. Dr. Tirumurugan, do you want to add up any comments or we can wrap up the session?
We really had a wonderful time both with Dr. Neelam and Dr. Arun Garg. And I think basically it hit the objective, it fulfilled the objective of this session. These sessions were supposed to give a perspective, and we definitely have achieved it. So thank you very much, ma'am. And we are really delighted that you could manage to just join us at the recover time, actually, in spite of traveling from Gujarat back to Chandigarh.
You can guess for whom I did this. For 3 people, 4 people, 5 people. For everybody of you.
Thanks.
Thanks, ma'am.
Thank you for being there. You're a darling. Thank you.
Thank you very much.
Thank you.
He's our chapter's secretary, so he's always a darling.
I know that. But you tell everybody like that, madam. You keep everybody close to your heart. We are very happy to have your love and affection for us. Thank you, ma'am. So we are very happy for all the delegates who have joined here for yet another interesting session on pediatric plunges for practitioners. And I really thank Dr. Ashwath for having been there in spite of his illness, and Dr. Singaravelu sir for coordinating, and Srinivas and many of the people who have joined, our seniors and the juniors alike, and it was a very exciting session. Thank you, Dr. Tirumurugan, for coordinating for the same.
Thank you, Singaravelu, for inviting me, and thank you, Dr. Thiru, and
thank you, ma'am. Thank you very much, ma'am. Very nice.
President, sir, of Tamil Nadu, I'm very fond of him. We've just got very close, and you have a dynamite amongst you all. There is no differential diagnosis for the dynamite.
Thank you.
Wow. Thank you. Thank you.
Thank you very much, ma'am. Good night.